Am I audible?
Yes, sir.
Yes, sir.
Yes, sir, you're audible.
Yeah, okay, thank you. So today we will discuss about the management of drug resistant TB. So you might have completed the treatment of TB, right? Tuberculosis.
Yes, sir.
That's good. And again, you have also visualized the program. Which program is related to tuberculosis?
RNTC.
Yes, good, very good. That is RNTCP. So revised National Tuberculosis Control Program, right? Okay. So today we will discuss about what we have to do when the TB case is confirmed as drug resistant TB, right? So before starting this, we will start with a small pre-test. Okay. Just you can take your pen and book. Just you can note down. Then after post-test also, you can check how many of you are being correct. Okay, we'll go with the first question. So what is the fluoroquinoline drug that is used as a part of shorter regimen of 9 to 11 months for multi-drug resistant TB? Levofloxacin, B. Ofloxacin, C. Moxifloxacin, D. Gatifloxacin. You can unmute and you can tell the option.
B. Ofloxacin.
Any options you want to pick? Any other students?
Oxyfloxacin.
Okay, 20% are picking ofloxacin, some are levofloxacin. Okay, we will see at the last which is the fluoroquine drug, right? Second question, identify the eminent person in this image. A. Louis Pasteur, B. Joseph Lister, C. Robert Koch, D. Edward Jenner.
Robert Koch.
Robert Koch.
Excellent.
Robert
So you are picking the option C as Robert Koch, majority of you. So we will see who is he at the end of the session. And this person is related to our tuberculosis. Third question, which of the following drug is associated with hypothyroidism? A. Isoniazid, B. Rifampicin, C. Linezolid, D. Para-aminosalicylic acid.
D. Paramount.
Any other options? So majority are, okay, majority are opening for D and some are for rifampicin, right? Thyroid disorder is a very important problem. So we have to know which drug will be associated with this hypothyroidism. We will see at the end of the session. Fourth question, what is the ideal dosage of ethionamide for an adult of MD, TB or TB patient who weighs 60 kg? 375 milligrams, 500 milligrams, 750 milligrams, and D 1000 milligrams. What might be the correct dosage? Again, if you know that table, so what are the different drugs and what is the weighing pattern in an adult, then you can only able to answer this question.
750 milligrams.
Okay, so one person is opting for 750 milligrams. Okay, we will see at the last and during the lecture also. So question number 5, what are the common adverse effects of kanamycin, which is also used in the treatment of this tuberculosis? So A, hepatotoxicity and neurotoxicity, B, phototoxicity and cardiac toxicity, C, hepatotoxicity and cardiac toxicity, D, nephrotoxicity and ototoxicity.
Nephrotoxicity and
Ototoxicity and ototoxicity.
D, sir.
Okay, majority are opening for D option, that is nephrotoxicity and ototoxicity. So this you might have heard in ENT also, right?
Yes.
Okay, we'll see at the during the lecture and then the post test. So question number C. So when was Old TB Day observed? December 1A, B March 24, C April 7, D September 17.
March 24.
March 24, sir.
Okay, majority are opening for March 24, that is B. Okay, we will see at the end When was the World TB Day observed? Okay, which of the following are the newer TB drug? Bedaquiline, delamanid, cycloserine, both A and B.
Both
Both A and B.
Excellent. So your majority are opening for both A and B, that is bedaquiline and delamanid. Okay, we will see during the lecture. Then dosage of bedaquiline for first 2 weeks is how much? 100 mg, 200 mg, 300 mg, and 400 mg. So how much?
200.
Okay. Any other options?
300 mg.
Okay, again they mixed the responses 200 mg, 300 mg. Okay, we'll see during the lecture. So what is the correct dosage of bedaquiline for the first 2 weeks? Then how much dose we have to continue for the next onwards? Okay, identify this instrument. Bactec MG8960, LPA, that is line probe assay, Gene Expert MTB or RIF, D TrueNat.
Gene expert.
Gene expert.
Okay, again mixed opinions of Gene Expert MTB or TrueNat. Okay, we will see during the lecture, and also end of the lecture we will see during the post test. Then question number 10, last one. Challenges in MDR or XDR TB. Long duration, poor efficacy, C toxic, D all of the above.
All of the above.
All of
Okay, so majority are opening for all of the above. Okay. Again, we'll see during the lecture what are the challenges we face during this MDR TB treatment or XDR TB treatment. Okay. Okay, we will go into the today's lecture of MDR TB treatment. Again, you have here this classification of clinically confirmed or clinically diagnosed TB cases. Can you classify this? How can we classify this tuberculosis cases?
Presumptive.
Yes.
MDR.
Previously treated.
Presumptive.
XDR TB. You can unmute and you can tell. Again, you might be knowing by this time a lot of varieties of TB, right? You can tell all the varieties. So what are different
New
types
cases and previously
of?
treated.
Very good. That is new cases and previously treated. Any other classification of TB?
Pulmonary.
Pulmonary, extra pulmonary.
Very good. Excellent. That is pulmonary and extrapulmonary. That is one thing. Any other?
MDR.
Multi-drug resistant.
Okay. Again, depending on the drug resistant. Drug resistance, there are some varieties of tuberculosis. Okay. So again, you might have observed this. Depending on this anatomical site of disease, we can also classify into pulmonary and extrapulmonary, as you said. And depending on the history of previous treatment, as you said, new cases or previously treated cases. And depending on the drug resistance, again, they are classified into varieties, 5 to 6 varieties. Then depending on HIV status also, TB cases are divided into TB with HIV or TB with unknown HIV status or TB with no HIV, right? Okay, so our importance today's discussion is drug resistance. We will see what is the drug resistance in case of TB. Okay, we can classify based on the drug resistance into 6 varieties broadly based on the drugs susceptibility testing, right? So again, the first one is the monodrug resistance. The name itself is saying resistance to one first line anti-TB drug only, right? So we will see what are different first lines or second lines. Then second one, polydrug resistance. Again, the name itself is showing resistance to more than one first line anti-TB drug other than the both isoniazid and rifampicin. Then multidrug resistance. Again here resistance to at least both isoniazid and rifampicin. So here isoniazid and rifampicin are resistant. These are called multi-drug resistance. Then fourth one, extensive drug resistance. So here resistance to any fluoroquine which we are using for tuberculosis and any second line injectable drugs like capreomycin, kanamycin and amikacin. Again, these are in addition to isoniazid and rifampicin. So multi-drug resistance plus resistance of fluoroquine or and any second line injectable drugs will gives to extensive drug resistance TB, XDR TB. Then rifampicin resistance. Again, the name itself is showing resistance to rifampicin with or without resistance to other anti-TB drugs. Then pre-XDR TB. So here what we are difference with the XDR TB is resistance to any fluoroquine or we are using or not and any second line. Either fluoroquine or any second line also along with the isoniazid and rifampicin. We can classify them as pre-XDR stage classes of TB patients. So if it is and between fluoroquine and second line injectables, pre-XDR becomes XDR, that is extensive drug resistance TB. So this is the broad classification of based on the drug resistance. And again, depending on the treatment outcome, we can classify this TB patient into two. Patients treated for drug susceptible TB, that what you have heard in the last classes, and patients treated for drug resistant TB using the second line treatment. This is what we are seeing today. So here you are seeing a drug susceptible TB. Again, there is a limited resistance and it can be treatable with the 4 common drug regimen, what we are giving through the dots, right? Then the second stage, it goes to the MDR TB, which was we are seeing since 1990, and there will be a resistance to isoniazid and rifampicin. Again, we are inculcating the second line drugs here. Then if there is resistance to second line drugs, then we are saying it as XDR TB, which we are seeing since 2006. And again, treatment options are very seriously restricted. Then total drug resistance. Again, here in this case, at present it is not seen, but if it is came, that what it means, resistance to all available drugs and there are no treatment options. So how this drug resistant TB occurs? So you might have seen this beautiful picture during your previous lectures. What is this? Somebody please mute yourself. One of your microphone was not muted. We are hearing some disturbance. Okay, so this picture we have noticed in the pharmacology also, right? This is a mechanism of action of TB drugs. Sir, you might be saying isoniazid that inhibits cell wall synthesis, rifampicin inhibit RNA synthesis. Then injectable second line drugs like kanamycin, capreomycin, amikacin, which are targeting the protein synthesis and ATP synthesis affecting drugs. So this is the mechanism of action. So this instrument, what you have seen in the pretest, this is nothing but gene expert MTBR RIF. So this is nothing but a CBNAT. So CBNAT is a fancy word you might be hearing. That is cartridge-based nucleic acid amplification test. This is for simultaneous rapid tuberculosis diagnosis and rapid antibiotic sensitivity test. And it is an automated diagnostic test that can identify Mycobacterium tuberculosis DNA and resistance to rifampicin. And this is a game changer which is endorsed by the World Health Organization, this instrument. So we will see some statistics of this MDR TB. So this is the global burden of drug resistance to TB. So MDR TB cases, in the new patients, we are seeing 4.1%. In the previously treated patients, we are seeing about 19%. In India, it is about 12%. In XDR TB, so out of 6.2% of MDR TB cases were going to the XDR TB. Then isoniazid resistance, new patients, we are seeing 7.3% and previously treated, that is 14%. So this is a big chart, which you will be seeing in between the lecture also. This is integrated drug resistant TB algorithm, which is very important. So when you got a question across your final examinations, drug resistant TB, so you have to draw this beautiful TB algorithm diagram. That is starting with the presumptive TB, or all diagnosed TB patients. So again, these are the different vulnerable group like pediatric age groups, people living with HIV, extrapulmonary tuberculosis sites, smear negative, and these are the different persons. Then all these diagnosed persons and presumptive TB patients, we are doing with the CBNet, which we have seen in the previous slide. Then we can classify into rifampicin, depending on the rifampicin resistance, whether they are rifampicin resistant or rifampicin sensitive, right? Then again, it can be classified accordingly into different categories: fluoroquine resistance or isoniazid resistance or sensitive. Then depending on that, we are inculcating the newer drugs like bedaquiline. And again, we are moving through the DST guided treatment. So again, this chart we will see in between also, we will discuss there. So again, in the drug management of multi-drug resistant TB or rifampicin resistant TB. So this is a shorter regimen which we are using for these varieties of drug resistant TB. So it is a shorter regimen with 9 to 11 months of duration. Again, this is recommended in MDR or rifampicin resistant TB confirmed by molecular or phenotypic DST. Then susceptible to both fluoroquine and second line injectable by second line injectables. Then, so whom we will exclude for using this short term regimen? So that is previous treatment who has undergone for more than 1 month with fluoroquine or second line injectables, or extrapulmonary TB cases other than the pleural effusion or lymph node TB, and who are pregnant women. So these are excluded for giving this shorter term regimen. So which drugs we are giving? So again, you know, there are two phases: intensive phase and continuation phase. So intensive phase is of 4 to 6 months, in which we are giving drugs like kanamycin, moxifloxacin, high dose, clofazimine, pyrazinamide, ethambutol, ethionamide, isoniazid, high dose. So again, in the continuation phase, which lasts for 5 months, we are giving moxifloxacin high dose, clofazimine, pyrazinamide, ethambutol. So here, fluoroquine we are using is moxifloxacin, right? So we will move into the next variety of regimen. So this is a conventional multi-drug resistant TB regimen, which we are giving generalized. So we are giving for how much duration? That is 24 to 27 months. So again, there is an exclusion criteria as like shorter regimen. So we will exclude all the pregnant women, all the extrapulmonary tuberculosis cases other than pleural effusion and lymph node TB. So coming to the two phases, intensive phase and continuation phase. So intensive phase lasts for 6 to 9 months. Then the drugs we are giving is kanamycin, levofloxacin, ethionamide, cycloserine, ethambutol, pyrazinamide. Then in continuation phase, which lasts for 18 months, we are giving levofloxacin, ethionamide, cycloserine, or ethambutol. And again, you will find all these guidelines in the RNTCP PMDT guidelines in 2017. You can go through the guidelines which we are following now. So again, we are starting with the new drug for this multi-drug resistant cases, that is bedaquiline. So bedaquiline works by blocking an enzyme inside the Mycobacterium tuberculosis, that is simply ATP synthase as like other. So again, what is the dose recommended of this bedaquiline is, we are giving 400 mg dose per day for 2 weeks. And then we are decreasing the dose to 200 mg, which is taken thrice weekly. So again, between 2 doses, there should be at least 48 hours duration. So 400 mg at start for 2 weeks, then taper to 200 mg dose thrice weekly. This thing you have to remember, up to 6 months. So what are the different indications of bedaquiline? This is a newer drug, which is a game changer for this MDR TB. So again, MDR TB are rifampicin resistant TB patients not eligible for shorter duration, who are not eligible. Then MDR or rifampicin resistant TB with resistance to any or all fluoroquine or all injectable drugs. Then XDR TB patients, mixed pattern resistant TB patients, treatment failures of MDR TB plus fluoroquine or injectable resistance, or XDR TB, MDR or rifampicin resistant TB patients with extensive pulmonary lesions, advanced disease and those deemed at high risk for poor outcomes. So these are different indications where we can use this bedaquiline drug. Okay, this is the flowchart for treatment of MDR TB, where there is a fluoroquinolone resistance, right? So again, we are starting with a regimen with new drug or regimen without new drug. So again, you know the new drug is bedaquiline. So again, there are two phases, intensive phase or continuation phase. Intensive phase lasts for 6 to 9 months, and we are giving drugs like kanamycin, ethionamide, cycloserine, linezolid, clofazimine, pyrazinamide, which you have seen in the previous slides. And we are adding with 6 months of course of bedaquiline. In the continuation phase, we are giving ethionamide, cycloserine, linezolid, clofazimine for 18 months. So if you are not using the bedaquiline, that is our new drug, so you will be giving kanamycin. So we are adding fluoroquinolones like moxifloxacin high dose. The same with ethionamide, cycloserine, linezolid, clofazimine, and pyrazinamide. And again, in the continuation phase, we are adding moxifloxacin high dose. The remaining will be the same. So again, this is the different treatment chart of multi-drug resistant TB who are having resistance to second line injectables, SLIs. So again, if you are adding new drug or without new drug, the same intensive or continuation phase, except we are adding bedaquiline in the intensive phase and during the regimen without new drug. So here we are adding capreomycin. So in the previous slide you are seeing moxifloxacin. So here we are adding capreomycin. You have to remember when there is a resistance to second line injectables, the remaining will be the same. So this is the treatment of XDR TB cases, right? So again, there is regimen with new drug or regimen without new drug. So new drug is bedaquiline, we are using for 6 months. The same we are using here, adding with capreomycin in the intensive phase in the treatment of XDR TB. In the continuation phase of 18 months, again the same we are as seen in the previous slide. Regimen without new drug, we are giving both capreomycin and moxifloxacin high dose in the intensive phase of 6 to 9 months. In the continuation phase, we are adding moxifloxacin high dose. The remaining will be the same. So this is the different charts you have to remember when you got a question like XDR TB treatment. So you have to draw this simple diagram. This will fetch you good marks. So again, this is the treatment of isoniazid mono or poly and mixed pattern of drug resistant TB. So when there is a resistant to isoniazid and rifampicin susceptible, then in the intensive phase of 6 months, 3 to 6 months we are using. Then in the continuation phase, we are giving drugs for 6 months. And the drugs given are kanamycin, levofloxacin, rifampicin, ethambutol, pyrazinamide. So in the continuation phase, levofloxacin, rifampicin, ethambutol, pyrazinamide. So if there is a mixed pattern of drug resistant TB, again it may be consisting of H monopoly or resistance to fluoroquine or injectable drugs or linezolid. Then you are giving with capreomycin, ethionamide, linezolid, rifampicin, ethambutol, pyrazinamide. In the continuation phase, again it will last for 6 months. Again we are adding here ethionamide, linezolid. The remaining 3 drugs will be the same. So if it is a resistance to MDR TB or rifampicin resistance with addition to the fluoroquine or injectables, with addition to the linezolid or more, then you have to give modified XDR TB regimen with or without drug based on the DST, drug sensitivity testing. So this is the dosage chart which we are following, right? This from this chart you might be getting a lot of MCQs in our competitive exams when you are preparing for NEET or any other examinations. So here again, it will divide it into different 4 categories of body weight: 16 to 29, 30 to 45, 46 to 70, more than 70 kilograms. Again, these are all the drugs which are giving. You have to look over this chart, and again you have to remember at least a normal adult who is weighing 60 kilograms. So what is the dose which are giving for rifampicin? That is 60 milligram. Ethambutol 1200 milligrams. Pyrazinamide 1750 milligram. This is the basic pattern what you are seeing in our textbook. Then ethionamide also we are giving 750 milligrams in a 70 kg or 46 to 70 kg adult. Again, those are drugs for drug-resistant TB. So again, these are the other different drugs like cycloserine, linezolid, clofazimine, or amoxicillin or clavulanic acid. So again, pyridoxine also we are giving with a dose of 100 mg in an adult weighing 46 to 70 kilograms. So again, this algorithm, again, they are suspected to the CBNAT, that is DST, to check whether there are any resistance to rifampicin. Then again, it is subclassified again to check the resistance to isoniazid or fluoroquinolones. Whether you have to, who will be continuing the shorter regimen or who will be continuing the conventional regimen. And we can also detect with this chart who are isoniazid resistance, whether it is mono or polyresistant TB cases. Again, so once a patient, suspected patient comes to you, then you are diagnosed with the person, and during the course of treatment, they are converted to drug-resistant TB. Then how will you evaluate these patients? Like what you are doing the antenatal checkups, the same you have to do pre-treatment evaluation for all the drug-resistant TB patients. So again, it will be like clinical evaluation. You have to take the detailed history, height, weight, comorbidity, any other comorbidities like diabetes, hypertension, all the things you have to be noted. Then any social habits like alcohol or smoking, you have to note it in your questionnaire. Then any laboratory investigations you have to order, like hemogram with hemoglobin, platelet count, blood sugar you have to measure, because TB and DM, that is diabetes mellitus, they both will be showing a huge twin burden. One is communicable disease, another is non-communicable disease. We have to detect beforehand. So we have to order the blood sugar beforehand before starting the treatment. Then liver function tests, renal function tests, HIV test, urine routine examination, and urine pregnancy test if they are a woman of childbearing age group, that is 15 to 45. So other investigations also we will advise like chest radiograph or audiogram. Again, other additional pre-treatment evaluations which we will order like TSH for thyroid, then mental health evaluation, surgical evaluation for all the regimens. When you're starting the conventional regimen, shorter or rifampicin resistant TB regimen or newer drug regimen, so you have to order all these tests. Then you can order ECG in shorter rifampicin resistance or new drug regimen if you are starting those drugs. Then serum electrolytes, potassium, magnesium, and calcium we will order in the new drug regimen when we are giving the bedaquiline. So another drugs, newer drugs like delamanid also newer drug. So, but bedaquiline we are using much frequently. Then serum proteins, lipase and amylase are ophthalmologist opinion. We have to rule out the chorioretinitis or uveitis in case of we are giving newer drug regimen. So you have to give some pre-treatment counseling. So again, counseling of patients and close family members who are associated with the patient. That is disease and what is the mode of spread. You have to clear it to them, counsel them. Then treatment, what is the dosage schedule? What is the duration? What are the common side effects encountered with this regular treatment? What are the different consequences of treatment reception? What will happen if they stop or poor adherence? Then monitoring of treatment progress. So again, you have to counsel regarding the prevention of disease transmission between the individuals, mainly into the family members. And you have to screen the close contacts for TB, especially the children who are 5 years and below, very, very important. Then female patients, you have to counsel about the family planning during the course of treatment. And again, you will give your supportive care to these patients. So again, you have to identify and you have to address these comorbidity conditions like diabetes, liver disease, renal disease, neurological disorders. And again, you will be giving advice on stopping the substance abuse like tobacco or alcohol use during the course of treatment. Then you have to link to support schemes based on the socioeconomic status. Then nutrition assessment and support you have to provide during the course of treatment. So again, coming to treatment administration, again, management of drug-resistant TB, This will be done in the district centers or nodal centers in consultation with the drug resistant TB centers. And again, ensure the treatment adherence. This is very, very important because if they are missing doses, they are moving into the drug resistant TB. So if again there is a chance, they will move to XDR TBs. So again, there should be a strict insurance of treatment adherence by following DOT or logical and judiciously treatment supporter. Then information communication technology, we are using frequent calls or SMS reminder to these patients, and IVRS we are using, or electronic pill box. So whenever they're taking treatment, they're using the drug, then we will be knowing whether they're taken or not. So we are following the patient's treatment. So this is the monitoring progress in drug resistant TB during treatment. So again, these are different investigations: clinical, body weight, smear examination, culture, DST, audiometry, urine pregnancy test. So if it is an H monopoly, so again, when we will order the smear examination, again monthly in the intensive phase and in the extended phase. Again, when we'll start the culture in the shorter regimen, so end of the intensive phase or extended intensive phase and treatment. Coming to the conventional, so again, when we will order culture, so again monthly from third month to end of intensive phase, extensive phase, and quarterly in the continuation phase. Again, we will order the complete blood picture in the conventional or shorter regimens whenever there is clinically indicated. And these are different investigations. We will be ordered according to the regimen we are giving to the patient. So again, if there is an there will be some extension of intensive phase in drug resistant TB, which is some extension of intensive phase when compared to the normal TB treatment. That is, when you come across shorter TB regimen, that is extended by 2 months. Conventional MDR TB regimen will be extended intensive phase by 3 months. XDR means we will extend it by 6 months. Mixed drug resistant extended by 3 to 6 months. Again, so how to manage these treatment interruptions? So we know there may be no complete good adherence to this treatment. So again, we have to manage this. If they miss a dose, intensive phase or continuation phase. So what you have to say? So it should be completed prior to the switching over to the continuation phase or stopping treatment. They have to take all the drugs before entering into the next phases. Again, if they missed less than 1 month, so again the phases which they have missed, they should be continued, and duration of treatment to be extended to complete the intensive phase or continuation phase. If they missed more than 1 month, so previously we have discussed less than 1 month, it should be continued. If it is missed more than 1 month, so again they have to repeat drug sensitivity testing using CBNAT and to restart the DST guided treatment, right? Again, what we have to do, missed bedaquiline dose, less than 7 days, we have to continue the regimen and duration of treatment extended to complete intensive phase. If it is more than 7 consecutive days, again bedaquiline should be started from the first day. Again, they have to continue for 2 weeks, then the remaining 200 mg for the remaining 6 months. So there are different adverse effects. We are giving a lot of drugs to this drug resistant TB treatment, right? So starting with the kanamycin or capromycin, this will cause common drugs causing nephrotoxicity and ototoxicity. Then levofloxacin, arthralgia, moxifloxacin, QTC prolongation. So QTC prolongation you will be seeing with a lot of drugs, encountering with a lot of TB drugs. Again, para-aminosalicic acid, linezolid, bedaquiline or clofazimine. So here we are seeing the QTC prolongation. So is there any role of surgery in this MDR TB cases? Yes, there may be if it is a unilateral resectable disease and there is an absence of response to treatment, if there is an absence to response to treatment with effective anti-TB drugs, despite 6 to 9 months of regular treatment, you can go for unilateral resectable surgery. Then morbid complications of parenchymal disease like hemoptysis or bronchiectasis you have encountered. Again, there is a role of surgery in these cases. And if there is a reversion of culture to positive during treatment or relapse after treatment completion or high risk of failure or relapse, high degree of resistance or parenchymal involvement, then we can go for the surgery in this type of cases. So what is the treatment outcome in this type of drug resistant TB? So it may be cured, treatment completed, or treatment success. So again, Cured means treatment completed as recommended without evidence of failure and 3 or more consecutive culture taken at least 30 days apart during the continuation phase. And again, you have here the name treatment completed. This is completed as recommended without evidence of failure, but no record that 3 or more consecutive cultures taken at least 30 days apart or negative after intensive phase. So both we can consider as treatment success. So what it in case of shorter MD or TB regimen? Again, cure means treatment completed as recommended without evidence of failure and culture negative at end of treatment and on at least one previous occasion. So treatment completed means treatment completed according to guidelines but does not meet the definition for cure or treatment failure due to lack of microbiological results. So again, these two we can say it as treatment success. So this is the treatment outcome in the rifampicin resistance or MDR or XDR TB. So again, in addition to the previous slides, treatment may be failed. So that is treatment terminated or need for permanent regimen change of at least 2 or more anti-TB drugs in continuation phase due to a lot of conditions like microbiological conversions at the end of intensive phase or adverse drug reactions, a lot of things. Then another condition may be they have died, death. Then lost to follow up. Again, interruption for 1 consecutive month or more for any reason prior of being declared as failed. Again, not evaluated, unable to evaluate, whom no treatment outcome is assigned. Then regimen changed. So need for the permanent change of at least 1 or more anti-TB drugs prior to being declared as failure. Again, conversion to negative, 2 consecutive cultures taken at least 30 days apart. So again, so how much time we have to follow up this XDR or drug resistant cases? Again, we have to follow long period, like up to 2 years. And after completing the treatment, you have to follow up for every 6 months, 12 months, at 18 months, and at the 24 months after completing the treatment. And if they are symptomatic, again you have to clinically evaluate, do chest X-ray, smear, culture, and DST if culture is positive. So again, this MDR TB treatment is very challenging because current treatment involves long duration, like up to 2 years, combination of multiple drugs. There is a poor efficacy and it is toxic, expensive, and there is no fixed dose combination available till now. So this is very challenging treatment for tuberculosis. So again, when we come across some statistics of treatment outcome for MDR TB cases, so you have seen treatment success we are seeing in 46% cases, failed in 3% cases, lost in 20% cases, and 22% of people have died. So what it in case of XDR TB? So again, this is a big survey which is reported in Global Tuberculosis Report in 2017, which are done in 52 countries. So if it is XDR TB, success rate is a little bit lower, that is 30%, death is 28%, failed 21%, and lost or not evaluated is 20% case. And these are different factors which are contributing to the poor TB treatment outcome, including the acquired drug resistance. It may be broad categories due to healthcare providers, inappropriate treatment, which includes the lack of training, poor treatment support, or non-compliance with the guidelines. Then second broad category, drugs, inadequate quality or supply. Again, if there is a poor quality of medicines or drugs, they will end up in drug resistance. Poor storage conditions, wrong dose or combinations if you are giving to the patients. Then third category is patients inadequate drug intake or treatment response. So again, these conditions includes lack of information, lack of means to adhere to treatment, HIV conditions, tuberculosis, then diabetes mellitus, malabsorption, social or financial barriers. These are different conditions, factors contributing to poor TB resistance, poor TB treatment. So again, this drug resistance is completely preventable. So completely preventable. This thing you have to remember, and you have to educate the patients with drug resistance TB. So you have seen a lot of fancy themes in the World Tuberculosis Days, like end TB or end TB strategy. It's time to end the TB. So again, in this pictogram graph, you will be seeing when will be the World TB Day celebrated. That is, we will celebrate on the March 24, which is every time we will be celebrating the March 24 as World TB Day. Its time is the current theme of the World TB Day. So we will be seeing a small video. Is it audible?
ఇది 2 వారాల నుంచి ఉంది. 2 వారాల సినిమా చూడటానికేమో ఫస్ట్ డే ఫస్ట్ షో, దగ్గు పట్టుకుంటే 2 వారాల మరి ఇంత కేర్లెస్ పదండి నాకు. డాక్టర్ ఇంత సీరియస్ అయ్యారండి? ఏమనుకుంటున్నా? 2 వారాలకు పైగా మీకు దగ్గుంటే టీబీ అయి ఉండొచ్చు. వెంటనే డాక్టర్ని కలిసి ఒమ్ము పరీక్ష చేయించుకోండి. ఎందుకంటే ఈ టీబీ ఎవరికైనా రావచ్చా? ఒకవేళ వస్తే మర్చిపోకుండా కోర్స్ పూర్తి చేసి ఆ తర్వాత నిశ్చింతగా ఉండండి. అలా చేయకుంటే దీని నయం చేయడం చాలా కష్టం అయిపోతుందయ్యా నా మన్మధుడా. 2 వారాలకు పైగా దగ్గ, వెంటనే డాక్టర్ని కలిసి ఒమ్ము పరీక్ష చేయించుకోండి. టీబీ ఓడిపోతుంది, దేశం గెలుస్తుంది.
So this is the beautiful advertisement by the government of India for creating the awareness on TB. So right, we are at the end of the session, so we will go at the post test what we have seen during the lecture. How much you have learned during the lecture we will see now. You can unmute your mic and you can answer the options. So what is the fluoroquine drug that is used as a part of shorter regimen of 9 to 11 months for multi-drug resistant TB?
Oxyfloxacin.
Excellent. So again, this is a very common thing, that is moxifloxacin. Moxifloxacin is the fluoroquine which we are giving in a shorter regimen. So again, identify the eminent person in this image.
Robert Koch.
Yes. This is a simple question which you will be seen in microbiology or a lot of other places, or in the walls of medical college. That is Robert Koch, who is an eminent scientist, which is highly related to this tuberculosis. So which of the following drug is associated with hypothyroidism?
P-aminosalicylic acid.
Yes, any other? Yes, correct answer is the para-aminosalicylic acid. So again, you have to start diagnosing with hypothyroidism. That is, you have to send the sample for TSH. And this drug of PAS, which is associated with the hypothyroidism. So what is the ideal dose of ethionamide for an adult of MDR TB patient who weighs 60 kg?
750 milligrams.
750 milligrams.
That's good. You have to follow the table. Excellent. That is
15 milligrams per kg.
750 milligrams per kg body weight. You have to give. So what are the common adverse effects of kanamycin, which you have answered already in the pre-test?
Nephrotoxicity.
Ototoxicity.
Excellent. That is nephrotoxicity and ototoxicity. These are the two common adverse effects encountering to kanamycin. So when was World TB Day observed?
March 24th.
That's good. That is March 24. B is the correct option. So what is the December 1st?
AIDS National AIDS.
Yes, World AIDS Day.
AIDS Day.
April 7th?
World WHO Day.
Yes. World Health Day. That is World Health Day. What is September 17? So you have to check and you have to tell in the next class.
Yes,
And you might see in a circular regarding this September 17 recently, right? That is regarding the safety day. So which are the following are newer TB drugs?
Bedaquiline.
Bedaquiline.
Quilin and Delamine.
Delamin.
Both bedaquiline and delaminid.
D.
Both are the
D.
D. D is the correct answer.
400 mg.
So dose of bedaquiline for first 2 weeks is
400.
400.
mg.
400 mg once a day. Then after
2
that,
weeks.
how much the dose?
200 mg.
200 mg. So identify this instrument.
Gene expert.
MTB.
Yes, this is gene expert. That is CBNAT, also called CBNAT. So in the TrueNAT, we are using some small chip. This is gene expert or CBNAT you can also say, because this is an cartridge, what you are seeing, blue color one. Cartridge based nucleic acid amplification test. This is a very important short notes for your final exam. So what are the challenges involved in MDR or XDR TB? So again, all of the above.
All the above.
Long duration or poor efficacy, toxic, all these are different challenges we can encounter in the MDR TB. And again, I'm very thankful to the ICMR, NE, National Institute of Epidemiology, managed TB course. And this is a TB course regarding the managed TB. So this is a beautiful free course. You can enroll, you can go to the NPTEL website. This is given by the ICMR people. This is a free course, you can enroll and you can take an exam and you will get a beautiful certificate from the ICMR, right? Thank you.
Thank you,
Stay
sir.
safe.
Thank you, sir.